Hello, I'm Zach Erickson, and I'm a resident physician in internal medicine at the University of Iowa, um, with a strong interest in palliative care and plans for palliative care fellowship. And my research interests center around goals of care and medical decision making. And so that's what I'm here to talk about today. I don't have any relationships to disclose and no conflicts of interest. So, my objectives today in speaking to you are my hopes are that after hearing this talk, you'll be able to describe the role of palliative care to patients and also to be able to recognize when a palliative care consult might be appropriate, both in inpatient and outpatient settings. Also, to discuss goals of care as a framework for making medical decisions. And I'm also hoping that to help people become more familiar with advanced care planning, just at least very briefly. So, what is palliative care? There was a recent public opinion poll conducted by the Center to Advance Palliative Care, or CAPC, and this was a survey of the general public. And one of the questions in the survey was, how knowledgeable, if at all, are you about palliative care? And as you can see on the pie chart here, 70% said not at all knowledgeable. And there were another 8% that said they didn't know if they were knowledgeable, so I would tend to lump those in also with the not at all knowledgeable. So that gives us close to 80% of the general public not really knowing anything at all about what palliative care is. And so then it becomes very important as healthcare professionals for us to be able to explain that to patients. So one way of trying to look at what palliative care is, I guess, is to go by slogans or mottos of some of the main organizations in palliative care. And so I looked up a few of those. So the American Academy of Hospice and Palliative Medicine has a couple of different slogans or mottos. Physicians caring for patients with serious illness, or compassionate care at any stage of an illness. And then CAPC, the organization that I mentioned before, has a new motto of care across the continuum. And so the reason I included the worm comic in this slide is to bring out that palliative care, I think all of these slogans emphasize that palliative care is not just about care at the end of life. It really is about care across the continuum or at any stage or for anyone with a serious illness. It's often confused with hospice medicine, which is a part of palliative care. But I just wanted to really bring out that palliative care is not just care at the end of life. So part of the reason for for CAPC performing that poll was to come up with language that people responded positively to explain what palliative care is. And this is the definition that they came up with for palliative care. And I apologize for just reading word for word off my slides, but I think this is worth listening to word for word. So, palliative care is specialized medical care for people with serious illnesses. This type of care is focused on providing patients with relief from the symptoms, pain, and stress of a serious illness, whatever the diagnosis. The goal is to improve quality of life for both the patient and the family. Palliative care is provided by a team of doctors, nurses, and other specialists who work with the patients other doctors to provide an extra layer of support. Palliative care is appropriate at any age and at any stage in a serious illness, and can be provided together with curative treatment. So a couple things that I'd like to emphasize from this definition are that palliative care is really for anyone with a serious illness, and not only for the patient with the serious illness, but also for their family. And the wording has recently changed to saying serious illness versus life-threatening illness, advanced illness, because the research showed that patients and their families responded very well to serious illness. And so I think it's important to use that language. It's also important to understand that palliative care is a multidisciplinary field, including social work, music therapy, physical therapy, occupational therapy, chaplain, as well as physicians and nurses. And then another thing that I wanted to bring out too is that that's in addition to the patient's regular care team or primary care team. So on an inpatient service, the primary care team, or in an outpatient service, whatever doctor is caring for that serious illness. And in fact, the term palliative care comes from the Latin palliare, which means to cover or to coat. So just an extra layer of support. And again, that palliative care, as opposed to hospice care, can be provided even in the setting when curative treatments are being offered. So why are we even talking about palliative care today? There was a recent study that got a lot of press, and it was by Temmel and others in the New England Journal of Medicine. And I think it really illustrates the power of palliative care and gives us good cause to be talking about it today. So this was a study of 151 patients with non-small cell lung cancer, metastatic. The reason this cancer was chosen is it has a very well established prognosis. Most patients at diagnosis have survival less than a year. And these patients were randomized into, one other reason to choose this cancer is also it tends to have a very high burden of symptoms and burden associated with treatment as well. And so palliative care is very appropriate because of that. So these patients were randomized into two groups, one receiving standard therapy alone, so just their regular chemotherapy or radiation therapy or whatever the standard was, as determined by their oncologist as well. Or that standard therapy coupled with early palliative care, and that was defined as palliative care consultation within the first 3 weeks of diagnosis, and then at least monthly thereafter, but also as needed. So in this study, the patients were assessed according to a couple of standardized scales. One being the FACT-L, which is a functional assessment of cancer therapy, just to use as a measurement of quality of life. And that's a specific scale used in lung cancers. The other was the Hospital Anxiety and Depression Scale. The patients were evaluated both at baseline at the beginning of the study and then 12 weeks later. And what they were looking at as the primary outcome was just quality of life in these patients based on depression and functional status. And they also collected data on end-of-life care So not only survival, but what kinds of therapies they were receiving at or near the end of life as well. So the findings on this slide were not really all that surprising. I think that that's what the researchers expected to find, or what I would be expecting to find as well in a study like this. That overall, the palliative care group reported better quality of life. There were fewer patients in the palliative care group that reported depression, and as you can see, less than half as much depression in the palliative care group. And fewer patients in the palliative care group received aggressive end-of-life care. And how that was defined was whether there was admission to hospice within the last 3 days of life, no hospice at all, or if they were receiving chemotherapy within the last 2 weeks of life. And as you can see, again, nearly half as much aggressive end-of-life care in the palliative care group. What really made this study catch people's attention is that the median survival was significantly longer in the palliative care group by about 2.5 months. So that's really significant to me. You know, if you put this into just very layman's terms, the palliative care group lived longer, happier lives, I guess you could say. So they had less depression, better functional status, and lived longer. So, you know, I once, to paraphrase an oncologist that was speaking of this study, he said, if palliative care were a drug, it would be fast-tracked by now. You know, these results are really amazing, and that's why we're having this talk today. So moving on into when a palliative care consult might be appropriate, Campbell published a paper in the journal Critical Care, and this was specifically looking at palliative care consultation in the ICU. And she came up with this figure illustrating how she sees palliative care consults happening. As you can see, as long as a patient is functioning well on admission to the ICU, the majority of efforts are focused on cure and prolonging life. And then at the point where the prognosis is determined to be poor, there tends to be, you know, the idea of, okay, let's stop everything else we're doing and palliate. And death often ensues shortly thereafter. Okay. So this figure is one that there are a lot of different variations of this figure out there. The top part showing a model similar to the one on the previous slide, showing that what often happens is there's active, aggressive intent, again, speaking more of goals of cure or prolongation of life, and then gears are suddenly shifted to palliative intent, and then there's death and bereavement. The figure B shows more of a model of how I think palliative care ought to fit in to the process of a chronic illness or even an acute and serious illness as CAPC defines it. And that is that palliative care ought to be involved from the beginning. The palliative needs, as far as comfort, symptom management, family counseling, decision making, may be fairly minimal towards the beginning of an illness. But as the illness progresses, the need for palliative care and palliative therapies increases. So Doctors Weissman and Meyer came up with a CAPC consensus on when palliative care consults ought to be considered, and they published this in the Journal of Palliative Medicine. And again, I'm going to apologize for reading a bit on this slide, but I don't see a good way around it, as these are just the list of criteria that they set forth. But so they have both primary and secondary criteria, both for assessment upon admission and then for daily patient assessments. So the primary criteria are in a patient with a potentially life-limiting or life-threatening condition, and I think now they would say a patient with serious illness, along with one of these primary. So the first one is the surprise question. So if the provider would not be surprised if this patient were to die within the next year, or in the case of pediatrics, before reaching adulthood. If the patient has frequent admissions to the hospital for the same condition. If admission is prompted by difficult to control symptoms. If they have complex care requirements, and again, this is in the setting of a potentially life-limiting or life-threatening condition. So, a lot of dependency at home, difficulty in performing ADLs, or need for home support for ventilation, feedings, nursing care at home. And then decline in function. And again, the part of this is failure to thrive. So, losing weight, not eating, or just in general decline in functional status. So the secondary criteria as part of consideration of a palliative care consult on admission are just any of these things in this list from admission, and this is even outside of the setting of life-threatening or life-limiting illness. So if they're being admitted from a care facility, patients with cognitive impairment or dementia with acute hip fracture, and that's coming from studies showing poor prognosis in these patients. Metastatic or incurable cancer, chronic home oxygen use, out-of-hospital cardiac arrest, past hospice enrollees, people with limited social support, and no history of completing advanced care planning, which we'll talk about later on in the talk. I think it's important to note that these secondary criteria are just times when the team ought to consider a palliative care consult, but at many hospitals, things like social support and so forth can be taken care of by the regular social worker, but it's just important to consider palliative care depending on the resources at your facility. And then there's a daily assessment as well. So again, the primary criteria are in the setting of life-limiting or life-threatening illness, and I bolded the ones that are different from the primary criteria upon admission. So in this case, an ICU length of stay greater than a week. Again, lack of clarity in what the goals are. So on admission, that would come from advanced care planning, but on the daily assessment, that would just come from, have the goals been discussed during the hospitalization, and are they documented? And then anytime there is a disagreement or differing of opinion regarding important medical decisions. And those disagreements can be between families, medical personnel, and the patients. And then the secondary criteria, all I think make a lot of just common sense. So I'll just go through those very quickly. So patients either awaiting transplant or ineligible for a transplant need to address emotional or spiritual or relationship stress. Any request for a palliative care or hospice consultation ought to be respected. And then if the patient is considering therapies like feeding tubes, trach tubes, dialysis, LVAD, or any kind of transplant, including bone marrow transplant. And then some hospitals have ethics consults. In hospitals where there is not an ethics consult team, often it's the palliative care team that is called in just because they have the skill set of discussing complex situations with families and with other practitioners. And so they tend to be very helpful in resolving ethical concerns. So I'd like to shift gears a little bit now that we waded through the list of reasons to consider consult and discuss a case. So this is a patient that I saw recently who is a man in his 60s, living in a care facility, has a long history of schizophrenia, which has been refractory to a lot of medical treatments. He was admitted with initially a leukocytopenia, which progressed to a pancytopenia, and this was in the setting of taking antipsychotic medications, some of which can cause cytopenias. But he also had elevated liver function tests and worsening psychosis, and so he was admitted. On evaluation, he was found to have enlarged lymph nodes, and lymphoma was suspected. So there were questions raised at that time, and I should note that the patient was unable to make his own medical decisions at that time. So the questions arose, should we even biopsy? If the diagnosis of lymphoma is established, would we treat? If we treat, how is he likely to tolerate treatments? Why are we treating? What are the goals? What was his quality of life before treatment? What would his quality of life likely be after treatment? So these are all things that went into consideration of both pursuing a diagnosis and then for making treatment decisions. So we'll come back to the case in a moment, but the case brings us to the role of goals of care and decision making in medicine. So this figure comes from a paper by Drs. Calgin and Broderick, published in the Joint Commission Journal. And their paper was discussing the implementation of using a goals of care framework in medical decision making, and specifically in discussions of code status. And this figure illustrates a general model for clinical decision making. And often physicians tend to focus on the intervention. So a patient will present to the hospital or a clinic, and sometimes we may not even have a diagnosis or a prognosis. And we just have an intervention in mind, whether it's further testing to get information, whether it's a therapeutic trial because of a diagnosis we think may be likely. And the intervention itself often receives the most attention. It's, and sometimes understandably so. A patient comes because they want something to be done. And so the intervention is, what are we going to do about this problem? As I said, there's not always a diagnosis or prognosis established. And if there is, it's not always really discussed with the patient or decision maker or family when medical decisions are made, or often under discussed. And then what I think really often receives little to no attention is discussion of the goals, both with regards to what the clinician hopes to or expects to see as an outcome of the intervention, and then also and especially what the patient wants and what they see as important and as their goals. And really, discussion of all three of those is necessary to be able to make appropriate medical decisions. In a study by Dr. Kaljan in 2008, this was actually a structured literature review. They found 6 common goals that patients have. And they can be remembered by the mnemonic CLF, CLF, or I say Cliff, Cliff. And those goals are cure, live longer, improve or maintain function, comfort, life goals, and that's something specific they want to accomplish, like for example in the picture here, a backpacking trip, or there might be a wedding to attend, or finishing a book. That can be any number of things just that someone wants to complete. Family support, and in this case family support means not that the patient is wanting support from their family, but actually the reverse of that they feel that it's important to them to be able to provide support to their family members. I have a grandchild to care for, and so forth. And then in a later study by Dr. Haberly and others, a 7th goal was also established, and that's a goal of just establishing a diagnosis. So again, many people might come to the clinic or the hospital not knowing what's wrong, and their goal is simply to find out what's wrong. And then the other goals are dependent upon establishing that diagnosis. So to go back to the case for a moment, and I'll go back to this figure. We discussed with the decision maker, who was the patient's son, what our options were as far as establishing the diagnosis, what we thought the likely diagnosis was, what we could then do based on that diagnosis, and then what he felt his father would want in this case. He did decide to pursue the diagnosis and got a biopsy showing Hodgkin's lymphoma, which is a treatable lymphoma and considered curable by the oncologists. And then was the question, then came the question about the burden of treatment, the likely outcomes, And this was also discussed that chemotherapy does come with burdens of severe illness, worsening of his cytopenias, all the unpleasant side effects of chemotherapy like nausea, vomiting, um, but that there was a possibility and a goal of cure that was felt to be attainable. And this spurred discussion of what the patient's quality of life was prior to his hospitalization. And it turned out that before coming to the hospital, despite his persistent psychotic symptoms, he was able to really enjoy his associations with the other residents in the facility where he was living. He was able to play cards. And it was felt like he really had an enjoyable life and a high quality of life, and that it's expected that he could return to that functional status. And so the decision was made to go ahead and treat. So I'd just like to, I think that's an example of how all the pieces come together to make medical decisions in a setting of goals. So this is another figure from the paper I mentioned by Calgin and Broderick. And this shows common treatment goals throughout the course of a chronic and progressive disease. So many goals can be held concurrently by a patient, and often throughout the course of a disease, those goals can change. And this illustrates a common progression, showing that often initially there may be a goal of cure, as well as prolonging life. And when it's found that cure may not be possible, prolonging life continues, as well as preserving function, as well as palliation of symptoms. And as each of those things progressively might not be very realistic or achievable anymore, shifts more and more towards just simply palliation of symptoms as a goal. I think one thing to point out about this figure is that initially all of those goals can be held concurrently, and I think often are by the patient, but I think by physicians sometimes, often it's not thought of as an overlap here, but rather there's a goal of cure, and then prolonging life, and then preserving function, and then palliation, when really they can all be coexistent. So another study by Calgin and others was a study of general medical inpatients. This was a survey study that looked at 135 patients, and they were asked about, first of all, what they understood about CPR, what their preferences would be regarding CPR, and then they were asked about their goals of care for their admission. It was found that patients had a very limited understanding of CPR, and very few of them could name all the components of in-hospital CPR. The majority could name only chest compressions as a part of CPR, and were not aware of, or were unable to name the other components such as electrocardioversion and mechanical or intubation and mechanical ventilation. And patients were also asked about their CPR preferences. Then they were informed about the likely outcomes of CPR, which were surprising to many of the patients. And then there was a discussion of goals of care, and then they were asked again about their understanding of CPR. So the majority of the patients in this study endorsed all of the 6 CLIF goals. But the important thing to note was that there was a broad distribution of what what they deemed as the most important goal, meaning that can't always assume that cure is the most important, for example. So all of those goals ought to be asked. The majority of patients at the conclusion of the study said that the conversation was helpful, and some patients even changed their preferences regarding CPR based on having this interview and this discussion. And this discussion was held not with one of their practitioners, but rather with the study group. So it was interesting that some of the patients even then elected to readdress the subject with their primary care team, and in fact, some of them changed their code status as a result of the discussion. Another study that was set up very similarly, but this time in ICU patients. And in this study, there were 100 patients in the medical ICU, and either the patients or their surrogate decision makers were interviewed using a format similar to the previous study. It was found that most respondents very greatly overestimated their chance of survival following CPR, with estimating about over 70% survival, when in fact the real numbers indicate more like 15 or 20% in hospital survivor following a code event. They found that a high prediction of survival correlated with full code status, and that seems to make sense. If you think the intervention is likely to work, you're more likely to want the interventions. In this study, an average of 5 cliff goals were affirmed. And I think the one of the big take-homes from this study is that 67% or 2/3 of the patients or their decision makers differed with the physicians regarding the most important goals of care. So maybe they affirmed 5 cliff goals, and that's an important step in decision making. But if the most important goal to the patient is palliation, for example, and the doctor feels like cure is the most important goal to be pursued, then there can be a world of difference in what therapies are performed and pursued. And so it's really important not only to talk about what the goals are, but really then to ask further, what is the most important goal for you as part of decision making? So to sum up kind of the goals of care framework for medical decision making, it's important to preface any discussion regarding a medical decision by a discussion of the diagnosis, if it's established, and the prognosis as well. And then discussion of the goals, including the most important goal. And then I think one thing that's also often left out is a discussion of what are the anticipated benefits. So if we do this such and such intervention, what gain do we expect to see? What's the likely outcome? What might be the burdens associated with that treatment? And all of that ought to be considered in making the decision. And then a shared decision ought to be made with the practitioners and the patient or decision makers. Documentation should always be made of those discussions and the outcomes of those discussions. And then this is really a fluid process. As more information is gained, or as treatments are tolerated or successful or unsuccessful, then these different components that go into making the decision are changing. And so this process is really a continual process. So what we've talked about so far was really more centered around inpatient care. And now I'd like to shift gears a little bit to advanced care planning, which I feel is really important and kind of goes back to um, the study I discussed initially about early palliative care in these patients with lung cancer. But really, for many illnesses, if we believe that palliative care ought to be initiated early, then it really needs to start in the outpatient setting before they're even hospitalized. So I'd like to bring up another kind of hypothetical case. 70-year-old woman with advanced dementia, living in a care facility, really unable to perform any self-care, has a fall and a hip fracture. And then there's discussion between, let's say, two daughters. One says, Mom's a fighter. Another says, Mom wouldn't want to live like this. There's no durable power of attorney. They both have equal decision-making power. So what do you do? Another example might be something more sudden. So this one you could argue maybe they saw it coming. The patient was already had dementia. Say you have a young man in his 30s, has a fall from a great height while at work, traumatic brain injury. Obviously, he was young and healthy, and no discussion had been made as far as what he would want, as has now a traumatic brain injury, unable to be weaned from the vent, and so forth. So what do you do? So if you take some of those examples, maybe those patients in the past had made a statement to their loved ones along the lines of, if I'm a vegetable, pull the plug. I think it's very common for people to make statements like that. And this is used as an example in a pamphlet by Perlman and others called Your Life, Your Choices regarding advanced care planning. How should that be interpreted? What is a vegetable? To some people, that might mean that you're unable to come off a ventilator, you're not ever going to regain your neurologic function or ever wake up again. To some people, though, it just means that they can't go on doing what they used to do. They can't take care of their own household anymore, manage their own finances, do the chores. Maybe it's that they're paraplegic or quadriplegic. Maybe it's that they have some lasting neurologic deficit and are not able to function on their own anymore. So it really needs to be spelled out in order for appropriate decisions to be made. And then there's the question of what is the plug? I think often people mean mechanical ventilation, but it can, life can also be prolonged by dialysis. It can be prolonged by enteral nutrition, feeding tubes. Would they want IV antibiotics for a severe infection? So it's really important that these things are discussed and spelled out in detail in order for decisions to be made. And this is not only for the good of the patient to ensure that decisions are made according to their wishes, but this also can relieve a great deal of the burden from the family. People don't want to have these discussions because they might feel uncomfortable having these discussions, but then when these situations arise for a family, it can be very distressing if they don't know what their loved one would really want. And there's a great burden, or can be a great burden, associated with trying to make these decisions. And a lot of that can be relieved if they can say, you know what, we talked about this before, and this is what they told me. And there can be a lot of comfort in that. So I just want to bring up kind of what the basic advanced directives are, and then there are a lot of resources out there for people uh, to look these up, and including the pamphlet by Perlman, which I found online, and the website is included in my references at the end. So the basic advanced directives are kind of in three categories. There are proxy directives, instructional directives, and personalized statements. So proxy directives are typically a durable power of attorney for healthcare. It can also be a a temporary guardian, or there are other legal definitions for it, but often it ends up being the durable power of attorney. And the important thing, again, in this case is one can appoint a durable power of attorney, but if no discussion is made regarding what a patient would want, then it lies the burden lies upon the durable power of attorney to guess what the patient would want. Yeah, you know, being the person hopefully that ought to know them well. So again, just because there is a durable power of attorney doesn't always mean that these discussions of advanced directives has been made. So it's important when speaking to patients about appointing a durable power of attorney that it's really stressed that they discuss with their power of attorney what their wishes would be. Instructional directives are the living will. These can be very specific and helpful. Often they're very vague. Another example of instructional directives here in Iowa is the iPost. Right now, it's currently in test phases and is offered just in Lynn County. It's a form specifically for patients in care facilities regarding their treatment preferences, not only as far as code status, but whether they would want admissions to the hospital at all, whether they would want enteral nutrition, antibiotics, and so it goes beyond just the code status. But this is a form that stays with the patient at the facility and then can be brought to the hospital in the event that a patient is transported to the hospital, and it just expresses their wishes. And then a personalized statement, which isn't really legally binding, but could be helpful to the family or decision maker. Just having a written statement of what the patient would want. But in the end, and I think the main take home for this lecture and for palliative care in general is that it's all about communication. There ought to be open discussion of diagnosis, prognosis, goals, burdens, and all of that, and expected outcomes, and all of that considered together leads to appropriate decisions. So I'd like to thank you all for your attention, and you can contact me at the University of Iowa if you have any questions. It's zachary-erickson@uiowa.edu. Here are my first references, and the rest of them. And again, thank you for your attention to this lecture.